These are my financial disclosures, and I have also to make a 20-year horizon disclosure. These commonly prescribed drugs are going to be 20 years old in 2035. And in 2035, I'm not going to be there to see what is, at least I think I will not be working as a clinician in 2035. And it's true that do we have data, 2 decades data on antiretrovirals? We don't have those data. We don't have the trials that we look at, they last 2, 4 years, 5 years maximum. When someone asks you what is going to happen with your antiretrovirals in 2 decades, I think the right thing to say is we don't know. We know that we have safer drugs, but we really don't know what is going to happen in 20 years. So that is an important disclosure. We are very fortunate in the developed world. We know that we look at the life expectancy of our HIV-infected patients, and you look in some, like in UK, there are many cohorts like this, and you look at the life expectancy of a person from UK, a male is 78 years, for a female is 82 years, and you see there in the different, where is the pointer? Sorry. Here. In the different CD4 strata, that if you have more than 350 and your viral load is below 400, your life expectancy is very similar in UK to the general population, both for females and for males. This is always with the best HIV, I would say, with HIV population without comorbidities, and they are on effective therapy. Several cohorts, when they look at these models, the life expectancy is very similar to the general population. So the consequence, the fortunate consequence of this is that our patients are aging. And this is a slide that is quite popular. It's from the Danish cohort, and you look at from the Netherlands, sorry. You look at the expected age of our patients. Here is broken down by different age strata. You see that the ones in 2030 that are going to grow the most are patients above 70 or patients between 60 and 70. And it's expected that the proportion of patients who are above 50 will increase 28% from 28% in 2010 to 73% in 2030. And the median age in 2010 will be almost 57 years. So our patients are getting older, and we know in our clinics that's something that we deal with every day. So what we want is that patients age in a good way. This is not only about quantity of life, it's about quality of life. And what we know already is that our patients have more comorbidities than HIV-negative subjects. This is a difficult issue to handle because the issue is about controls. So that's why I think this study from the Netherlands is very nice, because they get their HIV-negative subjects from the same sexual clinics that they have the HIV-positive patients. So this is, I guess, the best we can do to make the health behaviors more similar. So in general, this seems like good controls. And when you see these controls and you ask the question if your patient with HIV have more comorbidities, you see here that there is more hypertension, more non-AIDS cancer, more MIs, more peripheral artery disease, chronic liver disease, and cardiovascular disease. So it seems that and you can look at other cohorts, and it seems that they have more comorbidities, HIV-infected patients, than the general population. So still a controversy here is if what we are seeing is an issue of just accentuated aging in the top part. It means that these comorbidities occurred at the same age but with a higher frequency, or is an issue of accentuated aging that occur with more frequency but also occur earlier. And I think there is still not a definitive question to this issue. I'm not an expert on this. Here in the audience, I've seen Paddy Malone and Giovanni Guaraldi. Please refer your questions to them to solve these questions. What the task I have is, these are well-known international guidelines of antiretroviral therapy, the HHS guidelines, the IAS guidelines, VIVA, EACS, and GESIDA. And you see here what are the recommended regimens. In most of these guidelines, integrase inhibitors-based regimens are preferred, but also we have PIs and we have rilpivirine. So my job today is see what will be the possible impact 20 years from now in common comorbidities, and I've picked 3 of the most common, that is cardiovascular disease, bone disease, and kidney disease, always with the focus on what is the impact of the antiretrovirals on these comorbidities. With cardiovascular disease, we have 2 issues. It's the appears never-ending story of the relationship between abacavir and the risk of cardiovascular risk. This slide is very busy, but it's a nice summary of the cohorts that have looked at the issue if the use of abacavir is associated with an increase in cardiovascular risk. And this slide is broken down by the number of events, the number of myocardial infarctions that each cohort have, and these in the middle are cohorts with more than 100 events, or more than 100 MIs. These are less than 100, and this is the NA Accord study that look at another large cohort with 3 different types of analysis. Take-home message is that the cohorts that have the most power to find an association with abacavir and cardiovascular risk have detected an increase in the risk. You can see here the point estimates and the confidence intervals going around 1.70 increase of risk. The studies with less MIs, with less powers, you can see here a more spread type of risks, with some not finding a risk, with others finding a higher risk. And it's interesting that the NA Accord, depending on the analysis, found 3 different results. So in general, what I see in clinics is the very prudent clinicians, when they have a patient with a very high cardiovascular risk, they don't use abacavir. This is where the risk is most increased, and when the patients don't have a high cardiovascular risk, well, the opinion is still divided. We have to keep that in mind. The other issue with cardiovascular risk is what is the impact of each antiretroviral on the lipids of our patients, and this is a nice summary. Here in red, you have the impact of these drugs on lipid levels. Tenofovir difumarate, we have to be used to always to speak to 2 different types of tenofovir, difumarate or alafenamide. Tenofovir difumarate has a lipid lowering effect by itself. You know, if you give TDF to a healthy volunteer, lipids will go down, or total cholesterol will go down. TAF, tenofovir alafenamide, loses this lipid lowering effect. Raltegravir and dolutegravir has a very minimal impact on lipids. Abacavir is slightly higher, and then all boosted drugs, either with cobicistat or with ritonavir, have a higher impact on lipids. So that's easy to remember. This is an example of the difference between TDF and TAF, tenofovir difumarate or alafenamide. These are the pooled results of the 104 and 1111 studies. These studies were large, comparing antiretroviral naive patients, Strivil versus Hemboya. It's just comparing the selvitegravir boosted with cobicistat, and then FTC, and the nucleotides were either TAF or TDF. And these are the difference in lipids. This is what happened in the TAF group, baseline 160 total cholesterol milligrams per deciliter. Week 96 went up to 191. With TDF, the increase was less, and you can see here that these differences are statistically significant for total cholesterol and LDL, and not so for HDL or total cholesterol HDL ratio. So tenofovir alafenamide has not the lipid lowering effect that tenofovir difumarate has. So the question is, does these differences matter? So what as everybody does in the clinic, you use one of these cardiovascular risk calculators. This is from the American College of Cardiology. And if you look here, what will be the impact for a person, for a male who's 45, that is white, total cholesterol is you expose this patient for 2 years to TAF, and then total cholesterol goes from 160 to 191, HDL from 44 to 51. He's not hypertensive, he's not on hypertension treatment, he's not a diabetic he's not a smoker, so this patient doesn't need to start on statins because his cardiovascular risk, despite this total cholesterol change, is very small, is 1.6, so no statin recommendation. If we look to a patient that is similar, but same age, same race, but he has a systolic blood pressure of 150 and is on hypertension treatment and is a smoker, then when you go from 160, that is, you have baseline 160, the risk is 6.7%, and this recommendation tells you that you have to start in moderate intensity statin. So what is the relevance from going to 160 to 191? Was going from moderate intensity statin to high intensity statin. We've gone from 6.9, 6.7 to 7.6. So for this patient who has a higher cardiovascular risk, might mean you have to change the statin. And I think that's an important message. You have always to put into context all the changes depending on the other risk factors that the patients have for cardiovascular disease. And then you have to start an statin. It's always good to remember all the interactions that this drug have, and there are very nice tools to help with those interactions, like the Liverpool webpage, all these apps that we have to check for those interactions, that there is something important. Is this going to be a really big issue 20 years from now? Well, it depends. If we look at cohorts like this, to Kaiser Permanente in the States, and you look at the rates of MIs over time, this is in red HIV positive, in green HIV negative, you see that the rate seems to be becoming more comparable in recent years, both for MIs and also for a stroke. And that might mean that we are getting more aggressive to treat these high lipids, or can be that also we are using safer drugs. But I think this is good news, and if I've been asked to tell you what will happen 20 years from now, it seems that at least now this is not becoming more and more worrisome. So what about, if patients do not need statins and patients don't have cardiovascular events? This is going to be the next very large trial in HIV field. It's an NIH-sponsored trial. This is the REPRIEVE clinical trial. It's going to include 16,500 patients, and it's a very interesting trial because these patients do not need an statin because of their lipids levels, and they don't have established cardiovascular disease. And the randomization is very simple. It's placebo or pitavastatin, that is an statin that has very few interactions, and the endpoint is hard clinical endpoint is looking at cardiovascular events. So this study has the potential to answer the question that if this persistent inflammation that our patients have, even if they don't need an statin for their lipids or for their cardiovascular risk, statins can be beneficial in terms of avoiding cardiovascular events. So stay tuned for this trial. What about kidney disease? That is something that I have to pick until now one reason why I switch therapies in my patients, and one reason why I want them back to the clinic, so especially these patients that are really very well adapted to the treatment, will be to check their creatinines. We know that is something that can have bad consequences. So what is the impact on kidney disease of this? Well, we have to know, first of all, that it seems when cohorts have looked at the risk of kidney disease in HIV-infected patients compared to HIV-negative patients, two important messages is the absolute risk of chronic kidney disease in our HIV patients is low, but the relative risk compared to the HIV-negative patients is increased. In this particular cohort, you can see that the risk is increased almost 4 times of having chronic kidney disease. But it's important to remember both things, because relative risks sometimes are very alarming. This is 4 times, but the absolute risk is not that high, it's low. And we know that the drugs, when cohorts have looked at the impact of different antiretrovirals on the risk of chronic kidney disease, this is from DAD. You can see here what is the impact of exposure to tenofovir difumarate, and in different, these bars are color-coded by years of exposure. This is the longest exposure. I can't read it from here is, I think it's 7 years, right, from here. Well, with TDF, it seems that it's clearly an increase in the relative risk of having chronic kidney disease defined at eGFR below 60. With atazanavir, ritonavir, it's also increased, even in patients who didn't take tenofovir difumarate. With lopinavir, ritonavir is also increased, and not so much with other boosted PIs. The longer the exposure is not, the higher the risk, and also with abacavir, you can see here that the risk appears to be flat. So we know that there are differences among antiretrovirals in the risk of producing chronic kidney disease. And you have also tools to help you predict what is the risk of your patient of developing chronic kidney disease. This is a very simple score that the researchers from DAD have developed. You can see here, this is different characteristics of your patient, like being IV drug user, being Hep C antibody positive, age, different age strata, different baseline eGFRs, different CD4 cell count, being hypertensive, and all of these items are scored by the numbers. So you add the numbers, and for example, you have this IV drug user or with co-infected with hepatitis C that is between age 50 and 60. You have a score of 10 that is high risk of developing chronic kidney disease, and something that you can do up front. And you can combine this with the treatment that you are going to pick for this patient. And you can see here, this is very interesting, the number needed to harm. Is how many patients you have to start on these particular drugs. For example, you have here tenofovir difumarate, and you have a patient with a high risk score, like the one I've shown you, with a risk of a score of 10. You can see that only you have to treat 10 patients to have a chronic kidney disease with 5 years of exposure. So this helps you. In many patients, the drug that you pick is not going to be that relevant if you are in a low risk, but if you are in a high risk, this is relevant. Do we have other confirmations that this score works? I will see you in a minute. And we know that TDF was one of the drugs that appears that increase the risk. Again, there is a difference now with tenofovir alafenamide. You know that the blood levels of tenofovir alafenamide are much lower than the levels of tenofovir when you give it as tenofovir difumarate. And you look again in naive patients, the difference in the decrease in eGFR is almost double. After 1 year of follow-up, a decrease of 11 milliliters per minute with tenofovir difumarate and half with tenofovir alafenamide. So this difference matters. Again, it depends on what patient you have. And it's interesting, I think this is interesting, that when these investigators have applied the DAD score to these patients included in the 104 and 111 studies, you can see here the patients with high risk of chronic kidney disease, medium risk, and low risk. And it seems that the score is working, because when you see the rates of incident chronic kidney disease, it's clearly higher. It's 4.8% in patients with high risk and lower with the patients with chronic kidney disease. And here we are not talking about just a decrease in a number in eGFR. Here we are looking at development of chronic kidney disease, having an eGFR below 60. So that's the first good news, that the DAD score seems to work also in the context of a clinical trial. But also you can see here that there seems to be a difference between TDF and TAF. If you look at this hard endpoint, there is a difference. Numbers are small. Again, very few patients develop chronic kidney disease. Absolute risk is low, but it's increasing patients with a bad score, but it's also a difference in each strata. It's a difference between TDF and TAF. When there are other ways to look at renal toxicity, this is glomerular, but we can look at tubular toxicity. This is a more controversial area because the markers that we have not been clinically validated with a lot of precision. But when we look at the impact of these drugs in tubular function, and tubular function. A sophisticated way of looking at it is looking at these small molecules, small size proteins like retinol binding protein or beta-2 microglobulin, and we look at the ratios with creatinine in urine. You can see here that these ratios increase in patients treated with tenofovir difumarate and decrease in patients treated with tenofovir alafenamide. And again, you can see that by the DAD score, these changes seem to be higher in patients with high cardiovascular risk, high risk of chronic kidney disease. This has been seen with other drugs, with abacavir that you've seen in the DID cohort. It's not related to an increase of chronic kidney disease. When they look at these parameters, also beta-2 microglobulin and retinol binding protein, in this trial, a third trial comparing abacavir 3-TCF evidence versus TDF FTCF evidence, you can see here that the changes in these markers of tubular function were worse with tenofovir difumarate than with abacavir. And also, the issue that you have to be familiar with in this era of antiretroviral therapy is that we use several drugs that have an impact on tubular transporters. I never thought that being an ID doctor, I was going to become an expert on these obscure tubular transporters that I can, when I speak with nephrologists, I always make fun of them. They don't know, many of them don't know about MATE and OCT, but I have become an expert on this. I know that these drugs, these transporters, their job is getting the creatinine apart from other molecules from the blood to the urine. And you can see here there are two OCT2 and MATE1. Rilpivirine and dolutegravir inhibits this transporter, and then ritonavir and cobicistat inhibits this other one. So the important consequence for clinicians is that you can see an increase in creatinine levels. That means that if you calculate EGFR, it's a calculated EGFR, you are going to find a decrease in calculated EGFR, but not in actual EGFR. Okay, if you measure actual EGFR, it's not going to change. But for example, and this is really nice to see it, is you look at the comparison between TDF FTCF evidence or TDF FTC elbitergravir cobicistat, you see that this rapid increase in creatinine that occurs in part because of the cobicistat effect that is initial, but it doesn't get bigger. This is increasing creatinine as time goes by. And if you look at when this same comparison instead of efavirenz is with ritonavir, you can see that ritonavir also has this effect more than efavirenz. So it's something that we have to know. And also we have to know that with these recommended regimens, we have different cutoffs for starting therapy. With TDF, FTC, elbitergravir, cobicistat is 70 milliliters per minute. Here with TDF, FTC efavirenz, or with rilpivirine, or with abacavir, 3-TC dolutegravir is more than 50. And then when we have TAF on board, either with cobicistat or elbitergravir or with rilpivirine, is 30. So we have, even for patients with compromised renal function, we have drugs that their label allows us to use even with compromised renal function. So with bone, again, the same, when cohorts look at the impact of what happened with our HIV patients and bone, it seems when they do this meta-analysis that the risk of having a fracture is increased in HIV, pathologic fracture is increased in HIV-positive patients compared with HIV-negative patients, with all the caveats in these cohorts also that the issue about controls and the issue about how to control for different bias. But when you read these papers, you get the idea that our patients have more risk of pathological fractures, of osteoporosis, and more risk, and they have it earlier. So, and we know, and this is very well established, that if you start antiretroviral therapy, you are going to have a decrease in bone mineral density. This is one of the things when they have looked at the impact of in a start of early therapy or deferred therapy, apart from the big endpoint when they look at liver stiffness or they look at neurologic activity or neurocognitive function, they haven't found many things. But what we have found is, as expected, is that patients, remember, we've seen it, patients with more than 500 are randomized to start immediately or to wait until 350. And if you look at total hip BMD or total spine BMD, no matter patients who start earlier have a decrease around 2 to 3% in bone mineral density compared to patients with deferred therapy. So we know that antiretroviral therapy decreases BMD. And we know that there are differences among antiretrovirals in terms of the impact on bone mineral density. So this is the opposite graph that we have always for viral loads. For viral loads, always you want to have the longest line. With this is the impact on bone mineral density. You want to have the shortest line. And here you have change in spine bone mineral density, and this is change in hip bone mineral density. And you can see here in gray is always studies with tenofovir difumarate. And with tenofovir difumarate, you tend to see the highest decreases in bone mineral density after 48 weeks, around 3.5, 3.4%. The lowest decreases in bone mineral density are seen when you are using nucleoside sparing regimen, like we did in NIT 001 with darunavir and raltegravir, or when you are using TAF, is when you have the lowest decreases in bone mineral density. So the big question again, as all these complications, do the changes matter for your patient? Again, it depends on the patient you are seeing, and you have also you have a calculator for chronic kidney disease, a calculator for cardiovascular disease. You have this FRAX calculator for looking at the risk of fracture. And you can play with it and put different characteristics, and then you can do it with or without bone mineral density, but you can look at what will be the impact of a decrease of bone mineral density of 2 to 3%, depending on the baseline risk of your patient. And you can see for some patients will matter, for others will matter very least. And experts tend to agree that you have to consider HIV as a secondary cause of osteoporosis. And the other question is, does this matter in the long term? You've seen this decrease and this difference among antiretrovirals in the initial decrease in bone mineral density, but there are not that many long-term data. But if you look at this study that has been recently published, it's a follow-up of 7 years. The big difference between HIV-infected patients and HIV-negative patients is at the beginning, is in the first 2 years. Then even if you have started a patient on antiretroviral therapy, the difference with HIV-negative is clearly decreased. So still we don't have a question if these differences that we see with bone mineral density really matter in the long term. When we've compared TDF with TAF in different clinical trials, you've seen in even young patients or all type of ages a difference between TAF and TDF. Clearly with TAF you have a lower decrease of bone mineral density. You have to keep in mind it depends on your patient if it's going to matter a lot in the long time. With other antiretrovirals, we know from ACTG 5227 that everybody took Truvada, and they took 2 different boosted PIs, atazanavir, ritonavir, or darunavir, ritonavir, or raltegravir, an integrase inhibitors, and in this trial, decreases in bone mineral density were higher with boosted PIs than with raltegravir. So we can detect difference among retrovirals, but still, I would like that you take home the message that we don't know. It depends on the patient if the difference matter a lot. So there is still a search for even safer regimens. We live in an era in which really regimens are characterized even more by their safety than by their efficacy. And we have attempts to do different types of tricks with the regimens, so not to include toxic drugs. And we have these regimens that only includes a nucleoside with a boosted PI. We've seen data with atazanavir, ritonavir, and 3TC, or lopinavir, ritonavir, and 3TC, or darunavir, ritonavir, and 3TC. And we are seeing now, we're excited about combining dolutegravir with 3TC only in naive or in suppressed patients. That will be a regimen from the safety standpoint that could be quite safe, or even looking at nucleoside and ritonavir or cobicistat-sparing regimen with carbotegravir and rilpivirine. So stay tuned, because for these combinations we might have better safety, but they still have to be proven. And I think, I guess, my most important message, I've spent my clinic prescribing antiretrovirals, but you don't have to forget that the impact of antiretrovirals compared to other issues that our patients have is smaller. I will have to pick one. I spent, my Monday clinics telling people to stop smoking with very little success. And you can see here that the impact on survival, when I showed you the slide from the UK, that the life expectancy was about the same. Not if you smoke. If you smoke, that is important. And for each of the topics that I have covered for cardiovascular disease, from bone disease, and for kidney disease, there are other things that our patients do, other medications that are as important as the drugs we use to treat HIV. So in summary, we live in an era of safer regimens. There are fewer drugs recommended in naive, and the scrutiny is really on safety. We have safer drugs right now, but still we don't know if 20 years from now we will consider as safe as we consider them today. And I have picked 3 battlefields: lipid, bone, and renal, but there are other things we can comment later on, like neurocognitive or other things. So the goal is you can reach 50, be fat, diabetic, but ahead of you. You can look at this. Thank you.